Welcome to the Asking Why podcast. I'm your host, Clint Davis. I'm a marriage and family therapist and licensed professional counselor trained in trauma and addiction. The Asking Why podcast is for anyone on a journey of healing and restoration. If you are searching for answers to life's questions and want to learn more about root causes from a psychological and theological mix, this show is for you. In this podcast, myself and a co-host from Clint Davis Counseling and Integrative Wellness will interview guests on a wide range of topics in order to get down to the heart of the problems facing our world and understand why things happen and how to change the world and ourselves for the better. Want to learn more tips and tricks to living a healthy lifestyle? Visit us at Clint Davis Counseling and Integrative Wellness on Facebook and Instagram. If you want to meet our staff or book a speaker, go to clintdaviscounseling.com. Thanks for listening and be sure to subscribe today. All right. Welcome, Dr. Stephen Mcmullan, to the Asking Why podcast. Glad to have you, man.
Glad to be here.
Yeah. So me and you have been friends for a long time. We met in college, and over the course of the last, it's been like 15 years now since we've met each other?
Yeah, I think so. It's been a long time.
Yeah, both got married, both got kids.
I know, right?
It's crazy. I know. So tell me what, what you're doing now and, all that good fancy stuff.
Cool. So currently I live in Jacksonville, Florida. I am a family medicine physician by training, and I work at the Mayo Clinic here at one of their regional clinics. So it's all primary care doctors and what we call advanced practice providers. So, nurse practitioners and PAs. So right now I've been at that job since June of 2020. So I'm lucky I still had a job once everything went down through the pandemic. So, that's actually when I also got out of the Navy. So that's where I'm at. That's what I'm doing currently. Got a few other titles there as well. I'm a assistant medical student clerkship director. And so that's been a fun role. I've really enjoyed teaching medical students, and I'm also a site champion for point of care ultrasound. So we're starting to study how to use an ultrasound device to make certain diagnoses in clinic to spare patients having to go get it somewhere like an imaging center, or at least get them an answer a lot quicker from a clinical standpoint. So I'm looking into that. And then of course the main focus I have right now, which is what we're going to talk about today, is lifestyle medicine. So I'm currently working on becoming board certified in lifestyle medicine, and I will make a shameless plug for the American College of Lifestyle Medicine. Great resource for any health provider that might be listening, or a patient that wants to find a consolidated place where we put together all of the good studies and evidence supporting what we recommend through the Lifestyle College.
That's awesome. Yeah, for those of you that don't know, like me and Steve have been friends for a long time. We're pretty goofy together, so we're going to try to keep this serious as possible, but we're going to laugh a lot. So if you're watching the video, we're probably going to make really awkward faces and try to stay serious for 2 hours, and that'll be a surprise to everyone who knows our friendship.
It'll last about 10 minutes. And then it'll be just...
We could take it really far and really goofy really quickly. So one of the reasons, just for people listening, Steven's an awesome person, and I trust him implicitly. And so, as we've done this work of integrative wellness and therapy, and we've added a couple of doctors and pediatricians and chiropractors, he just has a good take on, medicine and where medicine's going and where medicine's come from. And so I thought it'd be a great idea to have him on here. So our goal today for people listening is just to open our minds to a different way of looking at health, a different way of looking at the medical care system, and seeing how mental health and physical health all kind of play a role together. In our other podcasts, we've kind of talked through dietitian things and trauma. And so we'll probably touch on a little bit of that, but that's the goal today for people listening. So, Stephen, kind of tell me, you said the Navy. So tell me about you. Like, how did you become a doctor? What was kind of your goal? What led you into the medical field?
Yeah, great question. So it's funny. I specifically remember when I was 18, about to go off to college to Louisiana Tech, which is
how about them dogs?
When I met. Go about them dogs. So I remember this like vividly. I still have a strong memory of this. I told my mom I will never become a doctor because it takes too long. I remember telling her that. So I clearly didn't know what I was going to do with my life when I went to college.
Yeah. Well, we were all going to just be in school for like 2 or 3 years, and we'd get out making $35,000 a year, and we'd be rich. You know, like I remember that. I was like, oh, I'm just getting out of here in like 3 years. I'll make like 30 grand, and I'll be able to pay all my bills and be happy for the rest of my life.
I know, right? Yeah, because I had zero income at that point. So
right, exactly. No perspective.
So I actually studied biomedical engineering in college, and you know, I was actually really interested in what's called tissue engineering. So that's basically where
like Charmin and
exactly tissue paper.
It would have been really important right now during the pandemic.
Yeah, very, very popular guy. Just like epidemiologists got really popular all of a sudden. I was like, they're never popular. They're epidemiologists. Anyway, so I wanted to do tissue engineering. So basically my big plan was, I want to be the first guy to grow a kidney, you know, like an artificial kidney, you know, from the person's own body cells. So then you don't have to worry about the transplant issues. And a lot of that stemmed from my aunt being a transplant nurse. She was the transplant coordinator for the only transplant center in Arkansas, where I'm from. So, so I had like that as a health member in my family, but everyone else worked for AT&T, like literally everyone else in my family. So I was like, well, I know I don't want to do that because I hear all their stories when I come home. It's like I'm not working in communications, that's for sure. So, so I did engineering, and I got probably 2 years into it, and I was really enjoying it, but I just couldn't see myself doing that, you know, whatever, you know, and I knew the breadth of the industry, but I just don't see myself doing that for the rest of my life. I was like, there's just something not there that I really want. So, so we have, you know, Clint and I have a mutual friend there, Lucius McGee, who was also, you know, we kind of saw him as Big Papi and mentor, and just a great all around man, that we had the pleasure and we're blessed to know. His brother's a pediatrician in Ruston. So I shadowed him a couple of times, just kind of like, honestly, just casting nets. Like I was like, I don't know what I want to do. Doctor seems kind of cool. It's a long road, but whatever. I'll go check it out. And I just remember that, I mean, within a couple of patient visits, I was like, oh my gosh, this is it. And I've always been kind of an intuitive person, just like making a decision, just like, yep, it felt right, you know, go for it. Now, of course, I don't really give myself any credit for that, but you know, at the time it was like, oh yeah, this feels right. This is good.
Yeah.
And I just remember Dr. McGee, you know, coming in and out of the rooms, the relationships he had with these people, like all the trust and, you know, that was going into that visit with him and between both of them, you know, between doctor and patient. And I think that's something that I picked up on pretty quick. And then integrating all the science and all that cool stuff, you know, kind of behind the scenes, you know, hearing him talk kind of about the medicine, and at the same time doing really well with the kids and the parents. I was like, this is it. So then I was like, oh crap, I have to figure out how to get into med school. So I was like way behind. Luckily I was already on the pre-med track, but I was like, I still have some catching up to do. So I had to scramble a little bit. And then, so that's basically the decision to go to medical school. And then, you know, the Navy was kind of an interesting situation. I had a recruiter, a healthcare in the Navy recruiter come by, and he, at the time it was the Biomedical Engineering Society. I was the president. So he wanted to just come talk to our society and just, you know, see if he could recruit some people. I was like, yeah, sure. Whatever. I don't know. And I remember like, he got out of the car and I met him, this guy, Chief Richard Fail. And he goes, you're going to be in the Navy. And I was like, okay, all right. Yeah. Sure, buddy.
Like, yeah, you don't know this guy.
Just come do your thing. I'm going to eat the free pizza.
Did you have your long hair at that point?
You know, I think it did. My samurai ponytail.
Oh, yeah.
That was great, man. Those were the days. So then, you know, so anyway, long story short, I talked with him a little bit. We kind of got into the process, and I was like, you know what? No, it's not for me. I'm doing it for the money. That's the wrong reason. Don't join the military for money. You know, that's not the right way to do it. And luckily I had good friends like Clint. I think we talked about it a little bit back then about, you know, just intentions and purpose and stuff like that. So then he bugged me for a whole year, and I was like, you know what, if you just take me to a base and let me meet some people, I'll consider it. Right. So I went on this trip.
I remember that.
Doctors. Yeah. Met some doctors at Portsmouth Naval Hospital. And honestly, that was that moment. It kind of clicked. I was like, these people, they're working together. They seem really motivated. They're having a good time. They just seem like good people. You know, you can kind of pick up on that pretty quick. So I was like, yeah, this is the kind of environment I could work in. And of course, back then, I had some ideas about what med school was going to be like, and being in the Navy. Like, oh yeah, you'll be able to work out every day. You'll have time put away, and you get to be on ships and stuff. None of that happened, by the way. But anyway, ended up joining the Navy. So graduate college, go to medical school. Got into medical school at University of Arkansas in Little Rock. And I will tell you, the first 2 years of medical school was a interesting experience. By far the hardest thing I've ever done. And definitely felt like I changed a little bit through that. Mm-hmm. And looking back, I don't know if I can still name what really happened. Definitely an adjustment disorder. I think if you want to go by DSM-5, just overwhelmed by the work that had to be put in to make it. Because to be honest, and this is going to sound really, cocky, and I don't mean to sound that way, but school was easy to that point. Even college was easy. Like making A's, it was easy. I got to med school and that was a reality check. Yeah. I got blasted.
I remember talking to you and you being kind of checked out.
I was not doing well. I was not making good grades. And of course you're on a curve in med school and everyone else is freaking smart too. Right. So It's like, oh geez, I didn't realize there was this many other smart people that are a lot smarter than me. And I'm like, oh man. But anyway, through having a really good friend group and we did we call it man breakfast, so a good kind of small group of guys that we, digging into the Bible, supporting each other, just having breakfast, having community, we all supported each other and we all just kind of made it, we did the best we could. Now, I will say third and fourth year were way better. Clinicals made a lot more sense to me. And that's when I had a lot of fun.
What advice would you give somebody who's kind of going through those first couple of years, coming out of college where it's easy, to have a better mental state or to have a better emotional state as they're going through it?
To be honest, man, I don't know. It's kind of like what they always said in the military, like, what can I do to get ready for special forces training? It's like, well, you probably really can't do anything other than more mental preparation. Mm-hmm. I think it's more mental preparation for the amount of work and the amount of pressure and the amount of stress that you're about to put yourself through. Yeah. I don't know if there's any amount of studying or any amount of like knowledge you can go in with, just like even from a they think about special forces, like there's no amount of you can't work out enough to just make it through. Yeah. Like so the best advice I would give is start kind of preparing to do probably one of the hardest things you've ever done in your life, from a school standpoint, and immediately find a community to support you through that. Yeah. That may be a spouse, that may be friends you already have, that may be friends you make in med school. And I'll tell you, the friends you make in the trenches of med school it's a shared suffering, as we say. So yeah, for sure. There's a trauma bond that goes with that. Yeah. And obviously my faith and us working through the small group side of it, but just those guys in general, those few guys that we still have a text string, still joking around, but it's like, there would be times where I was up and one of them was down, or I was down and one of them was up, and it just kind of worked out, so it's good. So I would just say, know who your support structures are, know who the people are that you would go to when you're not doing so good, and be vulnerable, be willing to admit. That was really hard for me to admit. I'll tell you, my first 8 weeks, I was not doing good at all, like grade wise. And again, when your validation comes from being the smart guy, yeah, and it being easy, then all of a sudden you're not the smart guy and it's really hard. Just personally, that was really difficult. Yeah. I know you. So, it's like you're a very charismatic, funny, bigger than life person, and you have a great time with everything. And I can imagine, that kind of smacking you between the eyes and not being able, like, that doesn't carry you through. You can be as chipper as you want to, and we can joke and be silly, but like, that's not gonna make you make good grades. It's not gonna, get the thing done. So I yeah. I remember you having really hard. I remember several phone calls that I've had with you, and that were, you were struggling. So I'm proud. I'm proud of you. I think, it's so cool now. I just saw you at the beach this year for the first time with your kids, and you get into getting married and all that stuff. But, to see where you've come from and where we both come from at Tech, and just being the immature, silly, recovering,
from our own family stuff and our own issues to now where we're still silly and recovering, but we're at least farther along the road than we were. I'm just super proud of you, man. And I think, it's a dream to have you on here and hear this stuff. So it's awesome.
Well, thanks, man.
Yeah, man.
I got a couple thoughts on that real quick. First of all, I'm also very proud of you. Again, I think from the days we first met, and I'll tell you, I don't know if I've ever told you this, but from the days we first met, I knew the potential you had. I could tell, you're just that kind of guy that just has natural charisma and natural leadership capabilities. Because some people have to go to the classes, they have to train, they have to learn, okay, how do I be a manager? How do I be a lead? Well, leadership mainly. You just have that natural ability to do that. And then it was more about honing it in, right? So, and again, I will also, my other point is I will owe you and the group of guys we developed community with in college to being able to do that in medical school, right? So if I had gone into medical school with never having to do that, to be vulnerable with other guys, to say what I'm not doing very good with and struggling with, and doing that in a Christian-based environment. If I hadn't done that, I would have been lost. I think
for sure.
because I wouldn't have found it in med school. Luckily, we all kind of came together, similar personalities and similar humor, and then oh by the way, we're all like, want to do this small group together. It really worked out in med school. But if I hadn't done it in college and hadn't established what that could look like, I would have happened to med school, to be honest. So again, I thank you for being that, that experience for me in college. And then again, I'm just extremely proud of you. I'm very proud of you, man.
Yeah, man. Same here. I mean, I remember, I'll forever cherish being on that, so Stephen and I led this Bible study with Lucius McGee for these 8th grade, 9th grade, sophomore kids when we were in college, but we were just kids too. And I'll never forget being on that youth retreat and just both of us being broken of our own stuff and crying and hugging each other and we're there to serve them and be the leaders and we're all having our moment. And so, it's just really cool to see what God has done. And so for people out there, wherever you're at, wherever you're at currently, there are people in your life who are going to be in there for a season. They're going to be there for life and they're going to come and go. But man, those bonds and those things, when it comes to being vulnerable and really sharing and learning those things together, they never really go away. And you'd be completely surprised, as we are today having this podcast, that, we'd both be married and have kids and, be professionals as much as professionals as we can be. We're doing pretty good so far without completely losing it. But so keep going. So when did you meet your wife? Was that?
I met Katie the summer after first year of medical school. So it was between first and second year. And, things had been getting better by that point. I actually just got back from my officer training for the Navy. And our kind of joke is I lost 30 pounds at that training.
I remember you coming back, because you were always thick. You were always the thick boy, big hair, thick. And then you came back and I was like, this dude's got abs and he's in shape. He's like a Navy guy.
Yeah. So they only let us eat 3 times a day. So that's what really got me. I couldn't have my ice cream at 11 like I always did in college.
For sure.
And I also couldn't have another certain beverage that anyway. So no, I lost a bunch of weight. I came back, and again, all good things, and that ties into what we're talking about later. But met Katie, and again, her and I's joke is she always thought I was the big goofy class clown guy. And then when I walked in the night we met, we kind of hung out that first time from the officer training. She was like, "Ooh, look at him,"
Uh-huh.
So. Yeah, I was like, "Oh, okay. How vain are you?" So
thank God, right?
I know, right? Worked out in my favor. So we started. We actually kind of a different story for another day, but became best friends kind of first. Which, looking back, I really appreciated that. And then and then we started dating, and then eventually got married. So, but anyway, she's a physician too. She's family practice, and she's actually doing a working from home kind of thing right now, which is really working out from a work-life balance standpoint, especially with the kids.
So
I graduated.
I had a really good guy who did your wedding.
Oh man. Let's not forget the wedding. We had the best minister you've ever met come to our wedding.
That was my first
the
one.
And the only.
I was so nervous.
Clint Davis.
I was so nervous. I remember having to get this Arkansas marriage license so I could do the thing.
We got
It
it
was a
though.
good time though. And then it was like, this pastor is drinking wine and dancing. Like, what is happening right now?
Yes, yes. We threw down at the
We had
reception.
a great time at the reception.
That was such a I thought that was a really great wedding. I thought it was
so
very
much fun,
very personal and intimate, and it was a good time. And I think anyway. So again, yeah, thanks for being our officiant.
I just remembered it as we were talking. I was like, oh yeah, because the time hop thing comes up every once in a while, and I always forget that I did. Yep.
So then graduate medical school, and I got a residency in Jacksonville, Florida. Didn't know anything about Jacksonville, Florida. Never, I think I'd only been there once, but it was like a mission trip years ago, years prior. So I didn't really remember much about it. So sorry.
It's okay. You're a doctor. Who knows?
So the,
you're like, I'm out.
And, so Jacksonville, Florida is where I got my residency spot. And then Katie got her spot at Mayo Clinic here in Jacksonville. So that's why that worked out, like, distance wise, so we didn't want to have to live apart if at all possible. And it really worked out, to our favor. So now residency was kind of its own animal. It was a lot of hours working, and it definitely was strenuous, but it was definitely a better environment, from a mental standpoint, than the first couple of years of med school. So I really did enjoy residency. I had a great time. Learned a heck of a lot. We did a lot, in Navy medicine, we're still full scope. So I'm delivering babies. We're doing inpatient. We're doing ICU care. We're doing like NICU, and then of course outpatient clinic and a bunch of procedures. So I learned a lot in residency, but it was really good. Met great people that I worked with. Unfortunately didn't learn a lot about the military because you're kind of in a bubble. So then my baptism to the military, so to speak, was after residency. Got stationed at Cherry Point, North Carolina, which is a Marine Corps Air Station. So got to hang out with some Marines for a few years, which are interesting people. Love them. Definitely, I have some family members that are Marines, so I like to give them a hard time. But we
get to do that right between branches. I mean, we get to make fun of each other, but nobody can,
of course,
make fun of us.
Yeah.
A lot of Air Force people in Shreveport, and I'd love to.
Well, yeah, Air Force is too easy though.
Oh yeah, the Navy's so hard.
The Navy. I know. For all our service members out there, we're joking. Yep. You guys know what we're talking about.
Yeah, exactly.
We appreciate all your service.
Don't cancel us.
So so my first duty station was in Cherry Point, North Carolina. So I'll tell you another kind of, again, one things I really appreciate your podcast is how people come on and they're kind of vulnerable about stuff that's gone down in their lives. And so here's my moment. So I experienced, I was probably about halfway through that tour. So probably about a year and a half in, maybe just close to 2 years in. And I've always kind of been an overachiever, go figure. Always tried to be best at everything I do. I tried to, I guess, and I wasn't good with boundaries at that time in my life. Mm-hmm. It's like, what's sad is I knew it, but I didn't do anything about it.
Right.
So I was saying yes to everything. I was doing everything. I was trying to be everything to everybody at work, for my patients, for at home, which unfortunately the home is what suffered probably the most of all of that. Because I thought that if I dove more into work and I did really well, somehow home would be better, which was really ridiculous. But I was just in this vicious cycle.
Absolutely.
I think. And then definitely experiencing what I guess the popular term, and I really don't like this term, is called burnout, mm-hmm. quote unquote. But I like to kind of call it what it is. If you want to call it dysthymia, if you want to call it adjustment disorder with depressed mood, whatever you want to call it, I was experiencing it. And again, it was one of the situations where I kind of knew I was, but I was in denial. Mm-hmm. I was like, if I just do this, if I just make it to this month, if I just get to this point, it'll get better. It'll get better. It'll get better. And, and I kept getting disappointed along the way. And it just mismatched expectations for what I thought people were capable of and what they actually did. For things like thinking I was making a really positive change in some process, and I was implementing it, and I was writing it all down, and we had it all going. And like 2 weeks later, whoever it is was going to go back to doing it the old way.
Yeah.
And it's just little roadblocks like that. But looking back, it's like, what I say now and what I realize is people will always be people, right? They will always be people. They'll be the best of people and they'll be the worst of people, but they will always be people. So I think it's the, clarifying what are my expectations, clarifying what are my goals, clarifying what matters to me the most. And I kind of had to go through a really low point to kind of realize, take that step back and realize that I don't have to be everything to everyone. I do need to set boundaries. I need to learn how to say no. I owe a little bit of that to this book I read called Essentialism, which I would put a plug in for that book. If you are kind of struggling with feeling like you feel like you have to do a whole lot, I'll tell you, you really don't. And in fact, you're actually more effective if you really focus in on the few things that you try to get really good at. And so that's why now at this point in my life, I'll fill in the gaps, but I've realized what I'm passionate about and what I'm good at and what my work needs. And that's that kind of middle of the Venn diagram where it's like the perfect spot, right?
Oh yeah.
So you can mix your passion with your skill set, with your institutional needs all together. And that's in the book, Essentialism. Then that's the sweet spot, right? So that's how you prevent kind of, losing some of that, the symptoms of something like burnout coming on is that when you're not quite in that middle zone, that's when that kind of starts to happen.
Oh yeah, man. It's tough. I mean, I think I hit that the October before last, it's starting to practice. Everything's going great. It's all these good things, but, didn't have the administration in place that I needed. Didn't have the personal assistant in place that I needed. Was trying to be everything for everybody and see too many people. And I remember talking to Ross, one of our therapists and one of my good friends here. And he was like, we were talking about trauma. And I said, well, I've already taken a break. Like I'm only taking a few clients here and there. And he was like, yeah, but you're taking all the hard ones. So I was waiting around and I'd wait until I had to take somebody or felt like it was God telling me to. And then I looked at my caseload and it was like Monday, car wreck, rape, human trafficking, divorce, abused child, that was just Monday. And then all the way to Friday. And I just didn't realize, and that had been fine for a long time, but I didn't realize I also now run a company and have other therapists and I'm having to supervise people. And so, this last year and a half has been, trying to figure out how many people to see and how many people to take care of and how many speaking engagements to say yes and no to. And, and it is a difficult thing, especially I know both of us are helpers and we love to be, do the best and have good intentions with that. And a couple of books helped me. One's called The Best Yes. And it's a really good book about, saying no to things and giving your best yes. And then the other one was recent, was like last October before last. It's called the Ruthless Elimination of Hurry. Have you heard of that? John Mark Comer.
No, I think you mentioned it on one of your other podcasts, but I remember I was like, I need to read that.
It's really good, but it's just talking about Jesus. Jesus was always busy and he always had things to do, but he was never in a hurry. And so, he's on the way to heal this lady, or this girl, this little kid, and the lady who comes and touches his garment and gets healed from the bleed. Like if he would have been in a hurry, he would have never stopped to be able to tend to what God wanted him to do and what was his best yes, so to speak, if we integrate both those books. So it's the same thing, man. I mean, we all think, and we're the same age, we're in the same season of life with kids and young kids. And it's you feel so old, but you also feel like a baby half the time when you're trying to learn to be mature and differentiate. And I think for people listening, you look at people who are doctors at the Mayo Clinic or professionals like myself, and sometimes you might think, oh, they have it all together, or, they've got everything figured out. And it's like, no, we're all just kind of doing the best we can and trying to be good enough and figure this out. So I appreciate that vulnerability from you. It's really, really helpful. It reminds me I'm not the only one too.
No. And and then, so to kind of fast forward, after that, there was a moment, that it all kind of came to not a screeching halt, but it just really kind of almost blew up in my face a little bit. Just realization of some habits I had gotten into and some coping mechanisms that were very negative. And just not listening to people telling me I wasn't doing that well, and just feeling like I could fix it myself. I can fix this. I can fix this. If I work out harder, I can fix this. If I try to sleep a little better, I can fix this. And realizing that there's a lot that goes into what was happening, and a lot of it really was my drive and my expectations that I kind of had to reassess. And so I did. I took a little bit of time. I think luckily we had a little vacation coming up, and I was just like, I just need to kind of pray about this and think about this. And it sort of hit me just try to say no to someone. It was sort of just do it, just try it, just try it on, And just simple things. Like I had to start really small, and I had to just kind of say no to something real simple, and then I was like, ooh, how'd that feel? Ooh, like dipping the toe in the water. And then
absolutely.
And then eventually I realized, oh, guess what? These people still come back and ask you for stuff. They still
the
like
needs
you,
never, the
I'm
needs
like,
never
wait, what
end.
was I had to like say yes to everyone. What am I thinking? Like, this is ridiculous. They're still going to come back and ask me to do things. So then it was empowering, right? Because then I'm like, oh, I can set this boundary with this person. They're not like all upset and offended. I'm not offended. I actually feel better because I didn't say yes to that thing.
Yeah. And even if they are offended, they're not offended for long. You know what I mean? Like, sometimes they're offended because you set a boundary, but then like they have to work through their own stuff with that and see you for who you are. And if they're super toxic, they'll go away. But if they're not, then they'll come back and you'll figure it out.
Yeah, exactly. Or we'll talk about it, right? Like that's kind of the mature way that we could handle it. And so anyway, so again, got better at saying no, got better at asking for what I wanted, which I wasn't very good at. And I had a few things that it actually, towards the end of me about to leave North Carolina to come down here, like stuff to do with like how much vacation I was going to get between duty stations and things like that. Like I vouched for myself and I felt good about it, you know, and like, and I'll tell you, my wife was a big helper. She was like, you need to go ask for this and vouch for yourself. I was like, okay, all right, I'll do it. Cause she's very, you've met Katie. She's very like, this is how it is. This is what I want.
Very much like JC for sure.
I mean, she asked me out, right?
Yeah.
That's the real story. She asked me out in med school because I was too scared to ask her. So anyway, she's always known what she wants, right? So anyway, just learning through kind of experience, again, taking small steps and just being in a different mindset. And I'm like, you know what? Like I'm happier. I'm more balanced. I feel more content. I'm still doing some stuff. I'm just not trying to do everything, you know? So it was very good experience right before I came to my next duty station, which was being a faculty for family medicine residents back here in Jacksonville. And I'll tell you, I absolutely loved that job. I mean, that was just a great experience. I love teaching, interacting with the residents, helping them through, being able to tell them my story that I just told on this podcast about really struggling in North Carolina and kind of what that was and what that meant, and how luckily I had really great support around me, and through just some personal journey was able to kind of work through that. So yeah, that was the 2 years there was really fantastic. And then honestly, if I could have stayed and worked there forever, I might have, but and then luckily, again, this job at Mayo Clinic kind of fell in my lap at not the last minute, but it was pretty close. I would already had like two or three interviews at other places. I was actually about to work out a contract, and then here we were, it kind of fell in my lap. And again, my wife was like, you need to go interview there. And I was like, I don't know, it's going to be like the military, they're going to tell me what to do all the time. And she was like, no, it's not. It's fantastic. You need just email them and tell them you want to interview. And I was like, okay. So I emailed the people, and they were so gracious and so helpful. And I came and interviewed, and I was like, this place is absolutely fantastic. I was like, this is the kind of place that I want to practice medicine. Please hire me. Please hire me. So then it worked out. I got hired in December of 2019. And then,
mean, it's so fun. I mean, it's so funny that you say that, because that's so many of us, is that we, and I won't get into all your family system drama, but like the reality is we all have stuff from our past that shape the way we cope and the way that we accept what we deserve and ask for what we need. And, even as adults with families and wives, thank God for our wives being women who challenge us and challenge us to ask for what we need and demand in some areas for us to be the healthiest version of us. And thank God for his grace that, instead of getting mad about that, we learn to have some humility and eat some, humble pie. Yeah. And like do the right thing. So I'm super proud of you that, because you do deserve it. You're a great person, a great doctor. And your patients would be missing out on something if you weren't there. So proud of you, man. It's awesome. You. Yeah.
Appreciate that. So then, started working. So of course, this is the last little bit of drama that happened. So, my wife was pregnant at the time with our third child.
I was going to get into that. Yeah.
And then I got deployed for COVID, which was not ideal.
I remember seeing you in the paper. I was like, man, look at this fancy guy down. Where did you go to Dallas or something? Where did you have to go?
Dallas. Yeah. I was in Dallas for 2 weeks, and then it was through various ways that they realized they didn't necessarily need us in the local area at that time. Then I ended up in Baton Rouge, actually, and the Navy was actually in Baton Rouge for quite a while. So So basically there was, I was there. I didn't actually end up seeing any patients while I was there, but it was at Baton Rouge Regional. And we just supported the local, physicians to be able to see COVID positive patients. So, and I'll tell you, man, it was kind of was like being back a little bit like home for me, because I haven't lived in Ruston for 4 years, and knowing a lot of people from South Louisiana, really had that Southern comfort, and I was like, oh man, this is like really good people, just good, nice people. It was really nice to do that. And then I came home at the end of April, and then we had our third baby, and then I got out of the Navy, and here I'm at Mayo Clinic. So
yeah, that's a good story. Yeah. I mean, I appreciate you sharing all that. I think for people, the thing about the podcast that I love is like getting to hear people's stories and then give people information so they have context. So I know one story that we kind of talked about on the phone recently, and we can get into that when we get there. But so for people, let's get into kind of the meat of the podcast. So we got another hour and a half to kind of talk. So just to give you a kind of timeline, we're good. But talk about like healthcare, where we've come from, where we've been to now, and kind of what you see about that changing and being different and good and bad and everything in between. I know that's a lot, but
yeah, man, that's great question. So I think that again, it won't go all the way back to when, doctors or physicians were kind of a thing. But I mean, if you think about it, for a very, very long time relative to the amount of time physicians have identified themselves as caretakers and medical experts, there really wasn't a whole lot, doctors could really do, like there was a few treatments they could maybe offer that were more natural remedies. Obviously they could provide kind of a compassionate presence. They could maybe try to identify what's going on with the patient, but in general, they were really more of just like supportive, kind of helpful, maybe a couple little treatments here and there. And that's really even up to the recent history. So you think about like the early 1900s. There really were no medications. I mean, there were some different substances we were using to try to treat different things.
Cocaine on the teeth and yeah,
cocaine in the nose and different things. Very interesting treatments that we were using. But eventually, as far as like the first true medications that came on the market, that was really penicillin. And that was in the kind of 50s timeframe, 40s, 50s. So,
which is insane to think about. Like,
right.
That's only, what I guess 50, 60, 70 years ago, in history.
Yeah.
It's just crazy.
Yeah, I know.
We think we're so advanced, and it's just like,
oh yeah,
we were still cutting, veterans' brains open, and so that they didn't have PTSD in the, 50s. It's just crazy.
Yeah, lobotomies, right? Lobotomies was a thing. So, so there were some really like kind of archaic, maybe even barbaric surgical procedures that were offered. And then otherwise it was like, I have this photo that I like kind of keep around. It's called the Country Doc. It was this Time magazine sort of expose of like what it meant to be a country doctor. And it was like pretty much all the pictures, the doctor's just sitting at the bedside with a sick patient, like not really able to do a whole lot,
right.
But just there, right? And it's interesting because the word doctor is actually from the Latin word docere, which means to teach. So really the essence to me of being a doctor is being able to teach, again, we get a large amount of knowledge, but then it's like, what is that? It doesn't really mean a whole lot if I can't help a patient kind of understand and learn what's really going on with them and what we're trying to do. I think that's a huge part of one of the things that we kind of miss out on, I think for various reasons. But again, I always try to remember teaching is really one of my main goals and really roles as a professional physician. So then kind of fast forward through the development of, again, through World War II, there's employer health insurance, right? Which was, again, not a thing really. You either paid in cash or you paid with your chickens on the farm, There's different models of care were started to form. And again, over the years, we designed a system. And I think initially it wasn't malintentioned at all. It just was designed around, well, you get paid, like I'm a doctor and I get paid because I do some things for you. I either do a procedure on you or I give you some kind of medication or some kind of injection. And then I get paid more because I did some more things to you as a patient. And again, I don't think the intentions were bad in how that formed, but that's the system we're in, right? It's the fee for service, if you will. So you can see where priorities can get a little out of line with what's really best for the majority of people that walk through the door.
Absolutely. Yeah, because it's a mess right now.
Yeah. Yeah. So then again, you have the health insurance industry kind of gaining speed. You have the pharmaceutical industry gaining speed as more medications are developed and more medication technologies are developed. I mean, even in, what was it, 2019, in just 2019, 48 new medications came on the market just in 2019.
It's crazy.
And a lot of them are little niche medicines for little different, very niche type diagnoses and things like that. But just puts it in perspective of how many different pharmaceuticals we're dealing with right now. That, I mean, I'll have patients come in with a medication list. I'm like, I don't know what 3 of those are. I've never even heard of them,
Right.
So I'm like, I have to look them up. I have to figure out what they are. What are they doing? So that's, just a perspective on that. And then more recently, it's really been kind of the big growth has been hospital administration. So administration in medicine has been kind of the latest sector to kind of grow and become very popular. And, I really do enjoy working with our hospital administrators, but that's not everyone's experience. So again, we end up in these models of care where it's different priorities end up where patients don't necessarily get put at the top, which is where, to me, the physician or provider patient relationship should be kind of the pinnacle of what everything kind of underneath sort of supports. Whereas there's, again, and that's my opinion, right? So that there's different models of how that should go. But I mean, in my experience, and the studies would even show that if a patient doesn't have trust with the person they're sitting in front of, how much are they really going to do for what they recommend and say?
Absolutely.
And if you look at things like malpractice claims, for example, one of the most common reasons a patient is actually suing a physician, it's not necessarily because of a profoundly neglectful action or definitely not like a malicious action, but it's more breakdowns in communication, lack of trust. Maybe the doctor wasn't listening to me, stuff like that. Like it's more kind of communication based issues. So, so what would make sense to me is to have a system that supports really healthy physician-patient communication and interaction. And again, we can go into why that matters later, but that if that is really the main goal of the institution, then really a lot of the other stuff should kind of fall into place.
Yeah, for sure.
You may not necessarily have to like monitor certain metrics all the time and have a spreadsheet that you're tracking, or talk about how your productivity as the doctor is not where it should be, and you're not meeting this metric because we need you to hit, you need to see this many patients per day, but you're not, you're only seeing this many patients per day. Again, I think that can breed some mistrust in the medical system. Patients feel like they're kind of not listened to. They come in and they get like 5 minutes at most with the doctor. The doctor's distracted.
Oh, yeah.
They're trying to type their note on the computer because there's 1,000 new things from the administration that they have to document that may not necessarily be relevant clinically, but they have to get it done because they want to get home to their families at the end of the day, and again, they start expressing those symptoms of, if you want to call it burnout, I'll call it adjustment disorder with depressed mood, where they're depersonalizing, they're being irritable.
For sure. I mean, we talked about this the other night, and I've talked about it with a bunch of doctors, but we're all humans, and we're in these systems where people forget that, and the humanity part of it, and how humans function, and how their brains and their emotions function. It becomes the last thing that we're looking at and dealing with, whether it's the doctor or the patient, and you get in an office and you've had a miscarriage, or you have cancer, or you have some issue, and the doctor's already, seen 100 people like you, and they have 100 things to do, and to survive, they've, repressed all of their emotions and feelings and experiences. And since they don't know that that's even happening because they have no training, now the patient's sitting there like, you really don't even see me as a person. You just see me as a number in a diagnosis in a book. And, that is a major problem, because the person is a whole person. And if they're talking about something that they feel, and they're talking about something that's emotional, and you just shut that down because it doesn't fit within the time or the model or the paperwork or whatever, then you get bad information. And I talk about this with lawyers. If you have a client who is in a personal injury case, and you're doing the same thing because you don't understand trauma and you don't understand the human mind, then they give you bad information on the stand. They give you bad information about the accident. And yeah, so if we could have a system in which people like myself and you collaborate to train, to work with people, doctors, lawyers, people who are dealing with humans on how humans actually work, and to be more trauma informed is what I would call it, therapeutic and how you do it. It doesn't mean you need to spend an hour and a half with somebody being a therapist. Like, that's my job. But if it's so simple to give a caveat or 2 more extra sentences because you know what you're doing, that can make the whole system work way better for everybody.
Yeah, absolutely. And again, I think, there's also this, I think this kind of the culture of medicine has kind of morphed into this. There's like an expectation, again, I think you mentioned this on the nutrition podcast you did, but you go to the doctor and then you like expect to get something, like a prescription.
Yeah.
So what I would, and a little plug here for lifestyle medicine is I am going to, one of the first things I'm going to develop is a prescription pad for lifestyle changes. So if you're coming in and you want a prescription, your prescription will be, maybe it's more physical activity. Maybe it's reducing salt in your diet to lower your blood pressure. Maybe it's some simple tips on how to cut down on or try to quit a nicotine product, for example. So that would be the prescription. It wouldn't be a medication.
Man, that's awesome. And people need that tangible thing too, because you can tell them face to face to do this, but when you give them homework and you actually write it down or have them write it down, there's something about that just connects with people so huge. Yeah. That's awesome, man. I love that idea.
Yeah, for sure. So I think go ahead.
No, just go ahead.
I was going to say, I just think we're in an interesting culture now in the medical community. I do think it's shifting. I think there's a bigger emphasis now on the kind of going back to probably really what it kind of was, years and years ago, before we had anything we could really do other than be just kind of a compassionate bedside presence, and kind of help people through and navigate, what was going on with them. And I think there has to be some acceptance, again, culturally, that there's just things that we in medicine still don't understand well. There are things that we can't necessarily cure. There's not always a pill to just fix symptoms that occur. Sometimes things kind of have to be done the hard way, and sometimes things are just a part of life, and I think there's some acceptance on the patient end, and then I think there's also some acceptance on the physician end. To just understand that, okay, is what I'm doing to this patient really helping them? Is this really improving their quality of life? Or is this like going to cause a side effect that's going to now have to be offset by another medicine to then treat that side effect that's going to interact with another medicine that's going to cause another side effect? You get in this side effect rodeo. And I'll tell you, so 2 of my favorite things to do is to de-prescribe. When I meet patients, I'll just start taking meds off their list. I'm like, you don't need that. You don't need that. You don't need that. That's probably not helping. That's interacting with that.
Yeah.
So that really makes me happy. And then again, focus on, and I focus a lot on quality of life. I use that phrase a lot in my practice. So I won't focus so much on, some metric or some number. I'll ask them, hey, how's your quality of life? What can we do to improve your quality of life? What's really bugging you that you think, man, if I could just work on this thing, I feel like I would be a better quality of life for me. Okay, let's and again, that's how you can kind of gain the patient's priorities out of that.
That's
right?
really good, man. Yeah. I mean, because the reality is you take something away from them that they don't want to be taken away, they're not going to give it up. If you're like, well, I see this as a problem, but they don't see it as a problem. So if I just tell them that it's a problem, they never, it's the same thing in therapy. They don't, it has to be their idea.
Yeah. And again, that gets into, hopefully as the communication strategies improve, the training improves, you learn communication strategies like motivational interviewing, specifically. So, motivationalinterviewing.org, for anybody that's interested. I have no financial relationships, but again, just the way as a healthcare provider in any discipline to just learn a better way to communicate with your patient and make sure that you're really focused on their priorities. And allowing them to come up with the ideas, right? So I call it learner-centered learning, right? So that's also the big push in academic medicine is to allow the learner to be the teacher, basically. Like they're the ones that are coming up with what maybe could have gone better, or maybe the knowledge deficit they might have had, or maybe the communication strategy they should have used, but they're the ones that realize it. So then they have that insight into what they can maybe go work on. So you're facilitating as the teacher, just helping them come up with the good ideas that they already know. And it's I see it the same with patients. And that comes with a few things. You have to create a safe environment, a trusting environment, just like you would with a learner, right? I can't go to a resident and ask them and challenge them to come up with a way to get, improve maybe the way they could have interacted with the patient if they're scared of me, or if they think I don't listen to them, or if they think that if they say something, I'm just going to ignore them, that has to be a safe environment.
Absolutely. And, you've heard me say this, and people have, if they listen to the podcast, but that's literally how the brain works. Like, that's trauma informed care. It's people are in their right brain, and they're, in fantasy and in music and in art and emotions, and they need you to validate them. They need you to make them feel safe. They need you to de-escalate all of that before they can learn in their left brain. Their left brain is logic and black and white thinking. And so, a lot of us have so much trauma and so much relational stuff going on. And for doctors and learners, like, we're all in, you're like in crisis. So they're coming to you with a major issue, which for them is crisis. And they're so right brain focused and so overwhelmed. And we give them all logical things. Doctors are like, do this, do. I remember, for our own experience with Grady, my oldest, and doing food allergy stuff, we would go, with weeks of no sleep. The night before, he woke up 19 times. We're in the allergist or the doctor. We're telling them the experience. We're emotional, and they're just giving us information. Never once did they say, have you been to therapy, or do you think this, could be an adjustment disorder or PTSD or, whatever. Your kid almost died 2 nights ago, like, let's talk about that. It was always just like, well, this is this and this is that. And you can't listen. You can't take it in, because the first thing you need as a human is to be taken care of and validated before you can take that information in. So I think that's such a great way of looking at it, man. I like that a lot.
Yeah. Yeah. So again, I hope that through, again, just things like this podcast, medical students I get to work with and teach, even just the patients I see, I hope I'm kind of can shift how people view that relationship they have with their physician, and actually see it as a very healthy relationship, where they can come in and they can be vulnerable. And, like I had a patient come in today, and he was very vulnerable with me, and he shared a lot of concerns he's had. And I was like, thank you for coming in and talking to me about stuff that I know is hard to talk about. I really appreciate you doing that. Simple things, simple communication strategies that just allow people to know, hey, I'm here for you. I'm listening, and I want to try to help, and in help in a way that's not, here's this pill, come back in 3 months. Yeah. It's okay. Let's find a strategy that makes sense for you. Let's be practical about this. I'm not going to ask you to quit. I'm not going to sit here and be like, you need to quit smoking when you're not ready to quit smoking. A, and we talked about this the other day, but B, I give you nothing else to do, right? People smoke for a reason.
Oh yeah. Don't take anybody's coping mechanisms without giving them something else.
Yeah. If I'm not willing to listen to the why or the drive, or maybe they don't even know, maybe they don't even understand why.
Well, they definitely don't know. Like, that's kind of the point, right? Is it's also that assumption that we don't know everything, but to remember that they need help knowing that they're not just doing it for bad reasons, that they usually haven't ever peeled back the layers of what's the root of the problem. And then doctors don't either. So then there's just, just symptom treatment. It's just Band-Aids over bullet holes, and we're just like, okay, we'll just stop doing this and stop doing this, and guess what? They're back in your office in however many months, still smoking or still eating or whatever it is.
Yeah. Reactive medicine is what I call it, and that's just not. I like proactive medicine. So I also
talk about that a little bit.
Yeah. So it kind of discourages me. Like, I hear, like, I had a young patient I met the other day, and came in, I think in their 20s, and basically came in and was like, well, my last doctor always wondered why I came in all the time to do my checkup, because they said I'm healthy and I don't need to be here. And I was like, I'm glad you're here. This is perfect. This is exactly the time that I need to either make sure you're educated on all the healthy lifestyles that will keep you healthy I always tell patients, I want to make sure you're kicking when you're 95, right? Like, that's my goal for you. Hopefully that's a goal you have, and if it's not, we'll talk about it, but we want to, and again, I'm like, hey, I want you to get to that retirement age and enjoy your retirement. I don't need you coming to see me all the time. You need to enjoy it, and let's keep you healthy. You're 25 years old in my office. I appreciate you being here, because a lot of 25-year-olds don't go to the doctor. And B, let's talk about, okay, what are the healthy lifestyle things that I recommend you do? And then if you're doing them already, I'm going to reinforce and encourage you to continue doing those. And I'm going to let you know I'm here for you if any of those start falling off the wagon, right? I'm here to talk with you about strategies to get back on those wagons. If you find yourself not exercising for a while, if you find yourself eating really crummy for a while. Again, there's seasons in life, and that's okay. And you can come talk to me about it, and we'll figure it out. Simple things like, hey, I'm not perfect, and I'm working on these things myself. But every patient I meet, I don't care if they're 6 years old or if they're 96 years old, I go over the same basic strategies with them, and I make sure they're doing them, because it doesn't matter what disease or lack of disease you have. The lifestyle things we're going to kind of dive into are all helpful and useful.
Absolutely. That's the big difference between, I love you said that, like reactive medicine and preventative medicine. Preventative, we've gotten so far away from that. And, and we can talk about COVID for a minute, but this idea, it's the same thing when people come to therapy. There are just some basic things that all of us can control that nobody wants to, because we all just want the pill. And American, consumerism is really, in the last 2 decades especially, has pushed us into this idea that, you can have it your way right away, right now. And we don't defer our reward. We don't know, they do the marshmallow test with kids where they put an Oreo or marshmallow, and it's like, if you can wait a few minutes, you get 2, or you can eat this. The large majority of kids eat the 1 immediately. We've no longer been able to wait for the thing and do the right thing we need to do to get the big payoff later. And that's fallen into medicine, mental health, money. My goodness, look at the credit debt that everybody's in, because they have to have the car, they have to have the house, they have to have the thing right now, not knowing they're going to pay for it at the end of their life. Right. Mm-hmm. We have to have that anxiety relief with the cigarette right now, not knowing that it's taking, 7 years off our life. It's just insane. And so I love what you're talking about from a medical model, because that preventative is it's harder on the front end. You have to, you're investing in yourself. Yeah. Right. You're investing in who you are and who you'll be at 90, or if you can be there at 90, and I think about my kids all the time. Like JC and I talk about it. I'm like, okay, I need to keep working out. I need to lift weights tonight. I want to go for a walk, because I want to be able to run around with my kids. I want to be able to run around with my grandkids. I don't want to be missing out on all of those things. We laugh a lot when we're traveling, because, especially when JC was breastfeeding, like she'd get up while I'm driving and go back to the back and be breastfeeding and then come back up to the front. And we would always say, like, how do people who are out of shape or obese do this? Like, how do you go pick up your kid's toy when they drop it in the back seat when you can't climb out of the front seat into the back? Then that might seem silly, but it's like, there's all these emotional, intimate attachment moments in being able to do those things and getting on the floor with your kids and playing a board game. And millions of people miss those things, and they miss out on life and connection and attachment because they're not doing the basic things. And and I know you're going to get in that in just a second, but and it's like, why? Right. So get into, I know you have like 7 pillars of what you want to talk about. So get into that.
I wish I had 7. It's only 6.
Oh, 6 pillars. My bad.
Maybe there's a bonus pillar.
Maybe I'll add a pillar.
Yeah. Clint Davis pillar. So the 6 pillars of lifestyle medicine are really kind of broken down, obviously 6 categories. So category 1 is nutrition, right? So we can talk about that. We can talk about them individually for sure. Category 2 is active lifestyle. So being active. Category 3 is sleep. So healthy sleep, which I know is a big problem for a lot of people. That's, again, everybody wants a quick fix on, but that's one of the toughest ones to work with, right?
Oh, for sure.
Category 4 is reducing or eliminating harmful substances for our bodies. Category 5 is going to be reducing stress, and then category 6 is it's by the ACLM, it's social connection, but I just kind of see it as general kind of psychological wellness, right? So the sort of the positive side of your psychology. So the social connection, the joy, the contentedness, all of those kinds of things that happiness, positivity, the stuff that makes life enjoyable, right? So those are the 6 pillars of lifestyle medicine, and those, and kind of going back to what you were just talking about, unfortunately, we haven't designed our medical care system to support putting that investment on the front end of educating. And again, it is a big task. It's not just the medical community. It's not just the mental health community. It's government and policy. It's schools. It's daycares. It's all of those kind of understanding that if these lifestyle behaviors, parents obviously as one of the main drivers,
absolutely,
lifestyle behaviors are taught and demonstrated from early on, they can be maintained and easily done the rest of your life, again, thinking of behaviors and habits. So, but if we don't really design our system to support that, then it's going to be all reactive, right? So if I, again, and this is the reality, if I get paid more as a doctor because you're sick and you're coming in a lot and needing a bunch of medications and treatments and injections and stuff cut off, well, it's better for my bottom dollar, right?
Yep.
But if, for example, and this is a new shift in the way medical payers may start paying for, is called a fee for care.
Mm-hmm.
So it's a set dollar amount that a medical facility would get, for example, to just care for the patients they have.
Yeah, so that's our doctor on staff, Dr. Mandy Crow, and I know she's going to be on in a few weeks.
So then the incentive shifts, right? So if you incentivize, and so for example, if you say, okay, you're going to get this X amount of dollars to take care of this group of patients, but if you get them healthier by these metrics, X, Y, Z, you'll make a bonus amount, like a 20% bonus.
Yeah, that's good.
So now you're incentivizing, okay, now what we need to work on with patients is getting them healthier, keeping them out of the office. When you have a set amount to pay all your overhead and all your staff, well, you're going to want to reduce your overhead and hopefully not reduce your staff too much. But you get what I'm saying, right? Like,
yeah, but you don't have to have them.
Yeah, then the idea then becomes, okay, well, if I can keep people out of my doors, then I don't need to pay a lot of extra costs. And then, so that keeps them healthy, that keeps them, not getting sick. So that, again, kind of shifting the model. But it's never too late, I tell people, to start incorporating these lifestyle changes.
Yeah, it's good. I mean, I would say the seventh one, since I'm making it up, is if I'll add it to your list, is like forming a foundational positive belief. Because underneath all of that, modification, they can't do it if they don't love themselves, if they don't value themselves, if they don't have a system underneath all of that in which says I deserve good things. Because all of those, all of the terrible things we do for ourselves is trying to cover up and cope with the terrible feelings we have of sadness and grief and loss and loneliness. And so we're just using all of these things, eating, drinking, not working out, to self-destruct. And so that's where, and I know me and you have talked about this and you believe it, but it's like, that's where the connection of, hey, you need a therapist, hey, you need to go work on your mental health, and not just your mental health, like coping skills, but you need to figure out what it is that keeps you from not being able to do these things that are the basic building blocks of a healthy life, pillars of a healthy lifestyle. So yeah, I mean, that's good stuff.
The base of the central core of the lifestyle training I've done so far, the central core theme, when understanding the person and the person's motivations is obviously, the middle of that core is the who.
Mm-hmm.
Who am I? What am I? What do I do? That defines kind of who I am. The identity, right? Kind of that basic kind of very inner core, identification of being comfortable in my, with who I am. I know what I'm about. Then kind of out from that flows all of these other things, right? So
that's great.
But yeah, if you don't know who you are, if you don't know kind of what you're about, that is something that I will work on with patients, because I'll ask them, hey, what are your health priorities? Well, I don't really know. I don't really have any. I'm like, okay, well, let's talk about that. What do you think that is? Oh, well, and then we kind of peel the layers back. Well, my parents didn't really talk about it much, and they never really did. They just ate whatever they wanted, and they're overweight, and they have. And I'm like, okay, well, and then again, using some of those motivational interviewing skills and learner-centered skills, it's like, okay, well, what do you think is something you might want to avoid in the future? What's a health condition you may not want? Or what about your parent situation, does it concerns you if I pick up on that? So kind of letting them realize, oh yeah, I don't really want to have diabetes when I'm, 55 years old. It's like, okay, well, let's talk about that. And then again, using lifestyle modifications and lifestyle changes, we could get there,
Absolutely. And it's also shame. So, it's also shame reduction. You're not saying I have all the answers and you're an idiot and can't believe you're doing your life like this, which is a lot of what, which is a lot of what sometimes medicine is. It's like, we are the ones who have all this information for you dummies who need to come in and get your stuff together. And people don't say that. And I'm not saying doctors intend that by any means. This is not about intention, right? I mean, I think there are a million doctors out there who have great intentions, who want to help people, and they're in a system in which they get lost. And it's the same for us as therapists. It's the same for all kinds of things, is that, we we lose that motivation, we lose that focus within the system that we're in.
Yeah, absolutely. So yeah, I think it's kind of shifting again, hopefully the culture and the environment that we care for patients, and to allow, again, creating a safe space where the focus is on, hey, we're a partnership and I want to understand your priorities, but I also want to make sure you know that what I've learned and what I know can be beneficial for you. That it can be helpful for you, but I want to meet you in the middle, and again, I'll get vulnerable with my patients, like, hey, I'm not perfect. I don't do all of these things all the time extremely well. I try to be, like you always say, I try to be good enough. I try to, and I don't, and one thing I used to do a lot is beat myself up for messing up or not doing well with something. But I'm like, for example, like you're taught you got to forgive others and forgiveness, like forgive yourself, for goodness sakes, learn how to forgive yourself and learn how to move on. Right? Like yesterday happened. Okay, let's move on. Let's do better this time. It's sure. Okay.
Yeah, I think and for us as Christians, it's like the forgiveness is already there. All you have to do is accept it. Right? I mean, it's so impossible for us to like let go of our own stuff because it's our stuff. But if we can accept forgiveness that's already freely given, by God, then it's an easier segue. Because I know for me, when I'm beating myself up about whatever imperfections I have, it's like, yeah, if I do that on my merit or my ability to not do those things, then it just eats me up. But if I can really accept the scandalous forgiveness that God has given me, then who am I, right, to forgive myself if God's already done that?
Yeah, exactly. Yeah. It's good. It's more just like the thought processes.
No,
like
for sure.
I got to beat myself up because I ate my cake. I ate the cake yesterday. I was like, let's talk about that. And again, going back to the nutrition, I really loved, by the way, the Ashley and Rachel, right? That did the nutrition podcast. I thought that was absolutely fantastic. Just again, relationship with food and our thought processes about food. I just had that discussion with a patient today because I mentioned, again, healthy lifestyle. This is for nutrition. This is what I recommend.
Do you hand out our podcast?
Do what?
I said you guys start handing out the podcast to people.
Oh yeah. I need to hand it out. Like, just listen to this. No, but she's like, oh gosh, I had cake yesterday and like acted all guilty. And I was like, well, I was like, I don't see any food as inherently good or bad. It's just food, right? And then so let's acknowledge that foods have different health profiles, and let's acknowledge that cake tastes really good. Like that's okay. It's full of sugar and butter and wheat, and that all tastes delicious. Let's admit that. To most people, let's admit that tastes delicious and that you enjoyed it, and that is okay.
Do you still like red velvet? Is that what your thing is?
I love red. Yeah, I love red velvet cake. That's right. Yeah, don't tell my secrets, man. But I'm like, but if you ate cake, most of the day, every day, well, then yeah, you're gonna have the health profile of cake is really not that helpful for you. It may, like that's how I like to see it, right? And that's I think what they were talking about is like let's not have a relationship that means it's inherently good or inherently bad. It's just food. And let's talk about what foods have a better health profile than other foods, and what foods do I know you can eat that will keep you the healthiest the longest and keep you out of my office. So that's how I kind of frame it that way. So that's a kind of a counseling tip. But so since we're talking about food, in general, the best recommendation is going to be a Mediterranean style diet or Mediterranean style way of eating. I hate the word diet, so I just say Mediterranean style way of eating or lifestyle, if you will. Generally plant-based is probably best, but I understand for a lot of people that's not part of their culture. That's not part of what they enjoy. So again, we meet in the middle, right? It's if you eat red meat every day, let's find some strategies to reduce that. I'm not going to say don't eat red meat to somebody that's a steak and potatoes kind of person.
Yeah.
Like let's work on that. Let's work with that.
What are you, a liberal? You're a liberal now? You want people to eat salads?
I know. Jeez. You eating salads? Rabbit food, man. Rabbit food.
Absolutely.
So
I get it, man. I always, JC, I'm like, what did you make? She's like, I made this pasta dish or blah, blah, blah. I'm like, is there meat in this? She's like, no, meat does not have to be in everything. It's like,
I know.
It's just an instinct, it's like.
No, it's like, where's the chicken?
Exactly.
Yeah. It's like, and hey, look, and look, I acknowledge that. Like, it's like, hey, if culturally you, like, I have, again, the other day I had a patient, she's like, I grew up in an Italian family. We love pasta. I was like, okay, then eat pasta. That's fine. Like, and I'm not going to tell you to eat whole wheat pasta, because let's be honest, it does not taste that
It's
great.
terrible. And it's not that much better for you.
It's just like, it's just not that satisfying, like in all reality. And I'm, shame on me for saying that, I guess. But anyway, I just say, hey, look, let's just focus on portions, or let's focus on the frequency.
Yep.
Like those are things that I think would be reasonable to think about, and, what could work best for you, and kind of throw it back to the patient and go, you know what, I could probably just eat it less frequently during the week. Okay, perfect. That's your first goal. You just set your first goal, go from every night to like 5 nights a week. It's your first goal, and then substitute it with X. Again, giving people something else that they can use in lieu of the thing you're asking them to stop. That's a huge part of lifestyle counseling, is to go, and it's easy for me to say, don't eat pasta, but I have to go, okay, well, I would advise you not to, probably don't need to eat as much pasta, but what else can you eat?
Yeah.
You can maybe try quinoa, maybe try lentils.
Spaghetti squash is really good. When JC has this thing that
zucchini squash, or zucchini noodles.
Yeah, it's super good, man.
Yeah. So again, just other ideas of like, okay, maybe try this instead, So really, and honestly, to be honest, that's really kind of it when it comes to the nutrition piece. It's not really complex. The way I break it down simplest to patients is I say, try to eat food that looks real.
Right. Look on the back of the box, and if it has 17 ingredients, you might not want to eat it.
Yeah. And honestly, if it's in a box, you probably shouldn't eat it. Let's be honest. So, and again, it's not, I don't like to talk in absolutes, but the general idea is, if the food has been changed in some kind of way, processed, if you will, usually stuff gets added to it in that processing feature, unless you did it yourself, right? Like you made the smoothie, you made the granola bar, whatever. That's, what's in it, right? No big deal. But you go into the store and you buy something in a package. Well, look at the label, read it, learn how to read it. Go talk to a nutritionist, let them help you work through that. Or just understand that it's, in general, try to focus on foods that just look real.
Yep.
It's fruits, it's vegetables, it's nuts, it's using olive oil as a cooking substance. It's whole grain carbohydrates like quinoa, lentils, beans, peas, barley, oats, things like that, in lieu of processed rice, processed pasta, processed bread, because that's all processed, right?
Yep.
So, like in Louisiana, I'm not going to show up in Louisiana and be like, hey guys, don't eat rice. Come on, let's be, and it just is realistic. It's like, okay, well, maybe we can work on portion sizes. Or in the Navy, I had a large Filipino population. I'm like, culturally, rice is huge. So it's like, I'm not going to ask you to take rice away. I'm just going to ask you to decrease your portion size, or maybe you don't eat it every day.
Absolutely.
Let's work on that. So anyway, that's just practical. Again, be practical. Work. That's what I would advise a healthcare provider to do: is be practical with your patient, work with them, meet them in the middle. Support them and encourage them. Give them the knowledge that'll help.
Well, you're also speaking to them as an individual instead of a group. And I think that's one of the biggest problems in so many systems now, is that because of efficiency, quote unquote, and money, we want to give everybody the general answer. We want to say, everybody needs to do this. Everybody needs to do that. Everybody who's this should do this. And it's like, man, we have to break it down of like, you tell me about you and what you can tolerate and what you can't tolerate and what your family system is and what you're used to and how that affects you emotionally. And yeah, that takes time, and you might not make as much money, long term, but you make the world a lot better place. You get people to do what you're asking them to do and make changes. And that in itself is such a payoff that you can never imagine.
Exactly. Yeah. So that's pretty much kind of the nutrition piece in a nutshell, pun intended. See what I did there?
Yep. Except for your allergy guys, it's a struggle. I will give a shout out to the allergy people. I know that, talking about food can always be like, well, I can't do any of that because I can eat like 12 things. So again, it's always just finding a way to do what's best for you and your body size and who you are.
Yeah, exactly. And again, like, that's my other caveat is like, look, the Mediterranean diet is kind of the general recommendation, but let's work together on what's going to work best for you.
Yep.
Maybe we incorporate a couple of the strategies underneath Mediterranean, but maybe there's some other things that just make more sense for you. Maybe you do have some sensitivities or allergies that we definitely need to keep that off your radar. And we'll be smart about that, and we'll work with our nutrition team and stuff like that. But, again, I think for the average person out there that's maybe looking for that kind of advice, or what should I be doing? That's generally what's the go-to, right? So, and I'll tell you, in our world, in medicine, the Mediterranean diet, as it's studied, has just tons of evidence of proven benefit to not only reduce the chances of getting things like high blood pressure, blockages in the arteries of the heart, or heart disease and heart attacks, strokes, diabetes, cancer. But even if you've already had those things happen, it reduces the chances of it happening again, right? And it can, in fact, there is good evidence now that we may even be able to reverse diabetes with just lifestyle modifications.
Wow, that's awesome.
Yeah, which is kind of mind blowing, because traditionally it's always been get them on medicine, give them insulin. That's the only way to treat diabetes. And now we're realizing, well, actually, if you do intensive lifestyle changes, you can actually just reverse the whole disease process, because it's a metabolic derangement.
Absolutely.
Meaning, yeah. So, but again, there's a whole lot that goes into that, right? So that's
not super simple.
The
that's another podcast.
Of all of this,
That's
the undertones of all of this is that we're asking people to change their behaviors, and that is a very difficult thing to ask people to do for many, many reasons. And you know that much better than I do. So, but
okay, so let's keep people on track. So what pillar are we on here?
That's nutrition. So exercise or active lifestyle. So active lifestyle, in general, that's how I like to frame it. So I don't like to frame it as exercise, because I think people think, oh, well, if I can't go out and do an hour a day of exercise, and then I just can't do it. I'm not gonna do exercise. And it's like, well, I don't want to think of it like exercise. And what's interesting, if you think about it, humans thousands of years ago, maybe even hundreds of years ago, they probably didn't actually exercise, because it wouldn't have made any sense, right? If you spend all day picking berries and finding nuts and trying to kill an animal,
herding cows,
you're getting water, you're herding cows, whatever you're doing it all day. Why would you come back to your cave or wherever the heck you're living and lift a rock 100 times? Workout of the day, CrossFit, bro. You like go full like why would you do that? That makes no sense. So like from a human history standpoint, exercise is a pretty new kind of thought or concept or phenomenon, like the treadmill, like that's all pretty new. So
because we can entertain ourselves and sit around. Like, I mean, I'm a therapist. I sit all day long, like I try to get up and stretch and go work out and do those things. But it's like, you have to now, because of how convenient life is for all of us and how comfortable not everybody. I mean, there's tons of people who have really hard lives who work their butts off every day. But a lot more people don't have to do that than used to, for sure.
Yeah. So I just remind people, like, what I want to focus on is just discussing an active lifestyle. So, set an alarm on your phone every 30 minutes to get up and move. Getting up once an hour is definitely recommended. Try to walk around for a minute or two, maybe do some push-ups, maybe do some air squats, do a breathing exercise, do something where you're getting up and you're moving and you're just changing your environment. I also remind people, because just stretch. Like I see a lot of professionals in the area, and I remind them, especially now everybody's working from home, which is a whole nother, we can talk about that later. But, in the professional world, or no matter what you do, your productivity goes up if you take regular breaks, believe it or not. It's not sitting at a computer and trying to do something for more than 20 minutes to 30 minutes is usually counterproductive. You kind of get, especially after lunch, right? We've all been there.
Sure.
You're dozing off, you're reading the same sentence 15 times. You're not really paying attention to what you're doing. So that's your cue to get up and move. Set that alarm, get up and move, take the stairs, walk from the back of the parking lot, stuff that's just totally out of the normal, right? Like we're always fighting over that parking spot really close to the Target or wherever we're going. And you get frustrated when you can't park real close. It's like, no, just park in the back. There's always spots in the back.
Absolutely.
Always.
We call it Target in Louisiana, Stephen.
Excuse me, Target. I know you guys got that French stuff going on. But yeah, like park in the back and walk and take the extra time to walk, like you never know, like maybe when you're walking from the back of the parking lot, you look up at the sky, you might see some birds up there, that you never would have noticed, so it's just simple stuff. So I go through some ideas. A lot of people don't like treadmills, right? Like they're just, like I did this.
Can't stand doing a treadmill.
Anyway, I don't like treadmills. I was going to say something about a gym here that has treadmills, but I'm like, I'm not going to put that out there, but I don't like treadmills. So, and I think a lot of people don't like treadmills. So I'd like to talk to people about, let's be practical about your activity, right? So maybe it's a walk around your neighborhood with your wife at night, or your spouse or whoever. Maybe it's a whole family outing, right? Your whole family, you do dinner and you all go, you put all your phones down and you go take a walk.
Yep.
Right. I mean, luckily I live in Florida. It's generally pretty much every day you can go outside. It's mostly sunny all the time. There's very few days you actually have to put a jacket on. So it's like there's no excuse to not get out after dinner and go take a walk, right, around your neighborhood.
Yeah, everybody can wake up and set their alarm and do 10 minutes of stretching.
Yes.
I mean, literally just bend over. Yep. Not every single person. There are people who can't get up and do it. But for the majority that we're talking to, the general public, we can get up and, roll our shoulders and breathe and touch our toes, or at least try to, and, move around a little bit, shake our hips, all the things that we need to do. And that literally, I mean, I do this almost every morning for jiu-jitsu, and it's like, it takes me like 10 minutes to do my whole body. And now I'm not super stretched out, but it's just like, it's a routine that I try to get into, and I forget about it. And then I pay for that. But the reality is like when I'm doing it, I'm like, I don't want to do this. And I'm like, I literally got a glass of coffee, sat down in the room. My son's next to me talking to me while I'm just stretching really quick. Like, but man, that starts my day off with such a purpose and such a the right oxytocin and the right chemicals and all those things.
Yeah, absolutely. And again, this is where I like to customize with patients. Okay. You don't like gyms. I get that. A lot of people don't. So what do you like to do? And they're like, I don't know. What'd you do when you were younger? I really like throwing the Frisbee. Well, why don't you find a way to throw the Frisbee? Go outside and throw the Frisbee. The best exercise or activity is fun exercise. And
Absolutely.
Activity, right? Because that's sustainable. You don't even know your heart rate's getting up because you're having a good time. That's the stuff that's gonna last you. So again, I like to work with people on that, but I just like to focus on it being an active lifestyle. The traditional recommendation is 150 minutes of moderate intensity exercise every week. Moderate intensity defined as difficult to hold at full conversation. So that's like a brisk walk. That's kind of a bike ride where you're pushing it a little bit. That could be a simple little game you're playing outside where you're moving, kind of gingerly. That's moderate intensity. So anything above that is more what we call vigorous exercise. And then in general, you can get less of that. And then there's actually a big study just published out of the United Kingdom that showed they actually tracked accelerometers on people. So like the technology that's in Fitbits and Apple Watches. And they tracked over many years, and they realized that the more active someone was, the more healthy they were in terms of outcomes, right? So they had less heart attack, less stroke, less high blood pressure, less diabetes, less cancer. So that was a linear relationship. So the more active they were, the less likely they were to have these things they were dealing with when they were older. So again, just a plug there that shows more is better to an extent. And then I also say anything's better than nothing. Okay. So don't feel overwhelmed that you have to do some crazy, super intense, high intensity, whatever, CrossFit, whatever you want to call it. Just you don't have to do crazy stuff. Just move. Yeah. Just
P90X.
move, so that's, yeah, P90, yeah, bro. Beach body. Anyway, so that's pretty much exercise, kind of in a nutshell there. So, and then the next pillar would be sleep. So, and this is, you could probably have a whole podcast on sleep, or at least I could talk for a long time about sleep. But here's the nitty gritty. The recommendation is 7 to 9 hours every night of ideally high quality sleep where you're restful, where it's relatively easy to fall asleep, relatively easy to stay asleep. And then of course you're not getting up to have to go to the bathroom a million times. If that's happening, come see your doctor. We'll talk about it. There's some practical ways to keep that at bay. But sleeping problems and sleeping issues is something I see a lot of people come to me for, and they may even come to you for. And in general, I see that as a symptom of something else going on, because it's very rare to have primary insomnia where they truly just can't fall asleep. There's usually something else going on. So we kind of try to unpack that. We talk about healthy sleep strategies, sleep hygiene, as we call it. And making sure that we talk about a practical kind of nighttime routine, and then what are you going to do when I wake up at 2 a.m. and I'm tossing and turning and can't go back to sleep? What do I do then? And I think everybody wants a medicine, and I'll tell you, even the sleep specialists, the American Sleep Society, highly recommends against using medication to help you sleep.
Yep.
So, and that's over the counter, not necessarily melatonin. Okay. I'm okay. That's generally accepted as totally fine. It's very safe, but pretty much anything else, Benadryl, your Tylenol PM, which is basically just Benadryl. Those are the antihistamines that help you feel sleepy. You've got all the sleep medicines out there, Ambien, Lunesta, Sonata, different Restoril, different types of sleep medicines. They're not sustainable. They come with side effects, and some of them have a risk of dementia. So,
yep.
So I have a long conversation.
They don't let you, is it true they don't let you get to REM sleep?
It's not that you don't get to REM sleep. They blunt the initial portion of sleep, which is usually the more restorative sleep. So when you get down to stage 4, you're very deep sleep, which is usually in the first 2 hours after falling asleep.
Yeah, deep sleep, not REM sleep, yep.
Yeah, so that's blunted by these medications. It's also blunted by alcohol. So I remind people, like, alcohol might help you feel sleepy and get to sleep at night. And again, you may be using it and again, we'll talk about this more in harmful substances, but you may be using it as a way to cope or be sleepy or reduce anxiety or whatever, or numb whatever emotional pain you're having. But you're not going to sleep well with it. You may feel like you're going to sleep really good after you drink a little bit because you feel sleepy, but that it blunts that time that you go down into the deeper sleep. And then of course, that doesn't restore you as well. So there's a lot of strategies. You can look it up on the ACLM about how to make your sleep environment as ideal as possible. Different little things, little tricks you can do to get into the mode of sleep to actually get your body more tired. I do remind people that any light, but definitely blue lights from like phones or screens is very, very stimulating to our brains. So really advise not doing that prior to going to bed, and then definitely not when you wake up in the middle of the night and you're tossing and turning. So pulling up your iPhone or your phone and looking through a bunch of stuff, that's just going to make you more awake. I always remind people, if you remember the last time you went camping, remember how tired you felt when the sun went down, and you think you're like, oh geez, it's got to be like 11 o'clock, and you look at your watch and it's like 8:30, and you're like, why am I so tired? It's because your body's doing its normal thing, which is when the sun goes down and the pineal gland doesn't have the light stimulation coming in, the melatonin levels start to go up naturally. And that makes you feel tired and sleepy and makes you want to go to sleep. Yeah. So all these artificial lights we have in our house, I tell people when you're closing in on that bedtime, the lights need to keep getting lower and lower and lower. You've already missed sunset. But it needs to be a lamp in the corner, not the big kitchen light that's on. You need to be careful with spending 30 minutes on your iPhone right before you're about to try to go to bed. And then other things I recommend are things like, again, a stretching routine, mindfulness, doing a mindfulness exercise, for example, praying, whatever it is that's more of a calming and peaceful type activity definitely can help you get into more of the sleep mindset. So just a couple of quick strategies there.
That's good. Yeah. I mean, we think it's like just with kids, but the reality is as humans, we all need that transition from the chaos of the day to going straight to sleep. Most of us are so busy, in a hurry, so to speak, that we're trying to entertain, it's like you work all day, you get home, you put the kids down, you eat dinner, and then you want to entertain yourself as much as possible before you do it all over again. And it's like you entertain yourself right up to, for me, 9 o'clock. And then I'm like,
Yeah. Now, again, a lot of these recommendations are for people who feel like they are having a little bit of a difficult time of sleep. I will say that even people that feel like they sleep just fine with like the TV on, I'm on my iPhone right before I fall asleep. Like it's probably not, you're probably okay, but it's not ideal, right? It's not the ideal way to and I'm guilty, man. I get in bed, I get on Google News and I'm like, what crazy stuff happened today? Trying to figure out what's going on. Then, I start feeling sleepy and I put my phone down and I fall asleep, but so I probably shouldn't do that. So I need to practice what I preach, but at the same time, people that do feel like they're struggling with their sleep or having a difficult time getting or staying asleep, definitely really, really take a step back and focus on those healthy behaviors of sleep, the sleep hygiene. And again, if you just type sleep hygiene in Google, right, you're going to get all kinds of resources and help with that. Go talk to your therapist about that, working on ways to do that. And of course, and what I try to do is I try to identify what is this a symptom of, so go talk to your doctor and let them know if you are having some anxiety that seems to be keeping you up, or you feel depressed and maybe because of that, you've gotten into this really weird sleep cycle or so just go talk to them.
Cool, man. So that's 3 pillars. We got 3 more.
Okay. Pillar 4 is reducing harmful substances or eliminating harmful substances. I think the low hanging fruit are the things like nicotine, or tobacco products, alcohol, and then other kind of addictive substances that we can talk about. So, and again, obviously big topic, lots of stuff to unpack, but I think the basics are, if you do feel like you're having a struggle or a hard time with these different substances, just again, reach out for help, ask for help. There's lots of resources available to help you out with that. Again, there's usually a lot more to the story than just, oh, I just drink a lot. You know, as you've mentioned of your prior podcast, I think it was 11 with Olivia Mason, I believe.
Man, look at you.
I think there was,
you really are watching my podcast.
I know, I'm a student of yours. Some really great points about, again, like the idea of a systems theory. I never heard of that until I heard that podcast. I was like, it totally makes sense. Like, I see people a lot too. You know, we see people in some of their most vulnerable states, and you go, oh, absolutely, it makes total sense.
Yeah.
So yeah, we're a product of the system we grew up in, and someone who's now drinking a lot of alcohol and maybe even addicted to drinking alcohol, that's not just in a vacuum, right? There's a lot more to that story. So,
absolutely.
So anyway, so my first plea would be to, hey, go ask for some help, okay? And again, you know, you definitely want to find an environment where you feel it's trustworthy and you feel safe to talk about what's going on. But here's the recommendation. Any nicotine product, to the best of our knowledge, does have some health consequences associated with it. Now, obviously, cigarettes are the most traditional one, and they do have probably the most severe health consequences. And it's so well known now that when I hear a lot of doctors, when they hear someone's a smoker, they get maybe judgmental, maybe kind of like almost like scoffing at it, like, oh, why would you smoke? You know? And I'm like, well, don't, that's not really a great reaction in my opinion. Really what it probably should be is I think most people who smoke know it's probably not good for them, you know? And I think they know that by now. I think most people know that.
It's right there on the pack.
Yeah, it says it.
Yeah.
Surgeon General.
Yeah.
But what the question I would ask is, hey, when did you start smoking? Why did you start
exactly
smoking? What does smoking do for you? You know, and then we can work on alternate strategies. I also remind patients, like, I'm not going to sit here and be judgmental about it. I'm not going to beat you over the head with it. I'm going to tell you what my recommendation is, but I know you're not ready until you're ready to really quit. It doesn't matter what I say. So again, that's the kind of framing the conversation that way. But yes, any nicotine products, so even the new products, the e-cigarettes, the vaping, you know, I have patients ask me a lot, oh, it's got to be better than cigarettes, right? It's better for me. And I'm like, well, relative to cigarettes, it's probably less dangerous. But so again, it's all about language. So words matter, right? So it's probably less dangerous than cigarettes to your health. However, it's definitely more dangerous than not vaping.
Yeah, for sure.
You know, like, remember that any nicotine exposure to your body, and again, let's acknowledge that nicotine can give you positive psychological effects. It can help you focus. It can help reduce your stress levels. Maybe it's a habit you've gotten into. Maybe it's just like, I get really stressed out when I'm in my office. I need to go outside and do something. And right now it's smoking cigarettes, or smoking, doing my vape or whatever. You know, let's talk about that. But that's, again, let's acknowledge that any nicotine exposure does come with some risks, health risks, and it's specifically cardiac disease and cancer risk. And then alcohol, right now, the general recommendation for alcohol is 2 standard drinks for men per day, or 1 standard drink for women per day. And ideally no episodes where there's 4 per episode for men or 3 per episode for women. And again, as a rare circumstance, so to speak. And again, you can look up what is a standard drink. You know, that's information's online. You can look that up. And then basically, now there's some recent data published out of Great Britain, of all countries, when it comes to alcohol consumption. No offense to anybody who's Britain, but that actually any alcohol exposure may not be good for us. So, and I know that that goes back and forth, right? So it's like, oh, a glass of red wine a day, it's really healthy for me. It's part of the Mediterranean diet. You know, again, I just always tell people, all things in moderation. And if you find yourself using alcohol for anything other than just kind of enjoying it, then maybe come talk to us. And if that enjoyment is a lot of drinks all at one time, if that's how you interpret enjoyment of it, then we also need to probably talk about that as well. Because there are health consequences associated with alcohol, such as high blood pressure, heart disease, stroke risk, AFib, which can lead to strokes. And then atrial fibrillation, that is a fast heart rhythm that you can get related to alcohol drinking. And then of course, liver disease. I think that's something people kind of know about.
It also triggers your anxiety and your depression and all kinds of things. So, I mean,
yeah, and it's a poor Band-Aid over a bleeding wound, to be honest, as far as a treatment. But it's understandable why people would want to use something like alcohol, because it is a depressing agent, right? So the receptors in the brain that it acts on basically help slow down brain processes. Again, hence feeling tired while you drink it. They reduce inhibitions. And relative numbing of emotions, and so you have, decisions were made, right?
Yes, decisions were made.
Decisions were made.
There's a Brad Paisley song about alcohol that's so true.
So again, and again, I am not perfect. I'm not the poster child of, have I had some moments where I drink probably more than I should have? Yeah. I mean, I luckily have never gotten in trouble, and I don't plan to.
I can attest to that.
Now that I have children, it's like it doesn't happen really ever, because the kids still get up at 6:30 or whatever, so.
Oh yeah. Speaking of that, the whole sleep thing, like if you have kids under 5, like you're out usually anyway.
Like I had a patient today. She's like, yeah, I've got twin 7-month-olds at home, and I was like, we'll talk about sleep, but it's a wash right now.
Yeah, we'll skip that pillar.
We'll just I'll mention it, but we all know it's gonna be a lot. And then okay, so pillar number 5 is reducing stress. Okay. Right. So
you've got 2 more to go, and we got about 15 minutes, just to give you a heads up.
Yeah, I'll be super quick. And so this is more your lane anyway. So reducing stress. So what I like to talk about with patients is if you are in a situation that feels stressful, I think let's try to identify why it feels stressful. Like, what is the trigger? What is the situation? What is the context? And then ultimately, let's talk about some strategies to try to reduce that stress. So I remind people, like, there's a lot in our lives that we try to control, but you just can't. Right? There's a lot that happens. Like I said, people are going to be people. And things are going to happen that are well outside your control. But what can you be empowered to do? And I like to use that term rather than what you can control. It's more about your empowerment and how you feel and react and cope with different things. Is, maybe it's your attitude, maybe it's your effort, maybe it's your mindset, maybe it's your perspective. These are things you can be empowered to shift and change. And we can talk about those as strategies to try to reduce stress. Maybe it's literally removing the stressor. If it's something easy to do or practical to do, or an environment you can change, then there you go. And sometimes people just need the validation of,
for sure.
Yes, that is a good choice for me, or that is a choice that'll probably help me feel healthier. And then I also remind people regular physical activity, taking care of your body, trying to get good sleep at night, trying to eat pretty decent food. All these other pillars kind of add up to reducing your stress. And then I'm a big fan of talking about mindfulness, teaching people mindfulness, cognitive behavioral therapy. I think a lot of primary care docs who really should be pretty well versed in mental health, disorders and treatment. Just as much as I can talk about Zoloft and all the side effects and risks and benefits and dosing and titration, I should be able to do CBT at least at a basic level.
Yeah, for sure.
That's my opinion.
Absolutely. Well, yeah. I mean, if you can just have a person doing some CBT, in the office, and then refer them out to somebody like us who does trauma therapy, who can get to the system stuff, who can work with addiction. Yeah, I mean, you're number one, you're validating the person right off the bat, which makes them feel safe, which then makes them feel like the person you're referring them to is actually legit and can be helpful. But if you're not touching that at all, and you're just saying go to therapy, then yeah, it's less likely for them to do it unless they're in a major crisis or they have someone else who is doing that.
Yeah. And I always introduce therapy as a option on a list of other things, because I think a lot of people want to hear about medicines. So I talk about them, but I'm like, hey, here's all the non-medication strategies that I know can help you. Mindfulness, make sure you're physically active, talking to a therapist, a specific strategy called cognitive behavioral therapy. And I'll even explain what that is on a really basic level, so they understand, oh, okay, so I'm just kind of working on something like a trigger or a situation right now or a context that really stresses me out, and I can maybe think about it differently, or maybe I can do something that helps me change my mindset about it, like kind of a simple strategy and a tool, tool in the toolbox. So that's kind of reducing stress. And again, if you feel, I just advise people, if you feel like it's getting overwhelming and you're feeling kind of less empowered, to have the emotional stability that you want in a situation, come in and talk to us about it. Let's talk about it and see what we can do. Lastly, it's going to be the more positive side to me of like this, of the psychological wellness. So social connection. Oh my gosh. I mean, that's maybe something we can dive into on a follow-up podcast.
For sure. We have a lot more to talk about.
Good. With everything going on with the pandemic, just the current state of adolescents growing up in a technologically advanced society. I mean, there's a lot. I actually give lectures on this about brain development and consequences of things like that. So the long and short is that good old fashioned social. I actually had this talk with a mom the other day. I think it was like a 15-year-old kid, and he was kind of complaining because he had a 2-hour limit on his phone. It would like shut off and he couldn't use it anymore. And mom's like, well, I was like, you know what? We're actually, the healthiest way for people to develop as growing up or even as adults is to just have good old fashioned human connection.
Right.
Just be with each other. We were like that for such a long time. Again, all of these changes, like everyone living in their own little house and not really knowing your neighbors.
Yep.
And
having backyards instead of front yards.
Backyards instead of front yards, going to work and coming home and not really having any engagement otherwise. This is all fairly new stuff. We used to all have to rely on each other, and social connection was a huge part of our development and a part of our health, our health and happiness.
Absolutely.
So again, I give people some practical ways to do that. It's all relative right now with COVID and the pandemic. And so I just remind people, like, don't miss out on reconnecting with people. You and I, good example, like years go by, right? And it's like, oh shoot, man, I haven't talked to Clint in a while. And here we are, saw you this summer, and then we touched base about this. And it's like, it's just I forgot how like encouraging it is and how motivating it is to see, like, it's like an old connection that you're like, God, it's still there, which is awesome.
Yeah,
and then,
for sure.
Like we can still laugh about the same stuff. Life has changed, but I mean, and it's just to see how much you've done and how proud I am of you. Like, that is a very joyful thing for me, and selfishly, I was like, I really love seeing what you're doing because it makes me feel good, So,
well, I mean, there is that part of it, right? I think it's methylate. Is that what it is? You're the doctor, but there's this. I went to this training a couple of years ago, and I was talking to one of the ladies said, never hesitate to methylate, and what she was saying is that when you eat green foods, when you exercise, all these pillars that you've been talking about, that you create this methyl in your brain that heals your brain and here's your neurochemistry and, knits things back together in the way they're supposed to. And one of the things she said is that, like, when you connect with other people, when you serve other people, when you see other people doing good, you create this methyl in your brain. And it's like, man, it's so true. And all those pillars are awesome, man. I mean, they're simple things that people can do, but it is a totally different view of medicine than what most of us get.
Yeah, absolutely. So, and then again, within that last one, it's just finding joy, finding the silver lining, changing your perspective, things like that. And there's different ways to do that, but that's kind of the final pillar, man.
That's good, man. I love that. I love that idea. I love the concept. And I know, we could talk about a million things and keep going.
Oh,
we will. One of the last things in the last kind of 4 or 5 minutes, I know and I'm going to gloss over it, so forgive me for doing it since we already talked about it. But one of the things we talked about was like doctors going through, surgeons, people going through what you go through, right? Being kind of a first responder on the front line of people who are a wreck at times. One of the things I want to talk about in the next podcast, but also just me and you keep up with over the course of the next couple of months, is like really doing some training for doctors. I know here in Shreveport, we're working on doing that for vicarious trauma, for burnout, for these adjustment disorders. And so any kind of tips that you can give or comments you can make to that would be helpful for maybe doctors listening or people who are nurses or healthcare providers.
Yeah. Kind of quickly, I'll say that probably the thing that has helped me the most, I would say, was changing my perspective on a patient situation that's difficult. So, for example, I have someone who really wants a specific substance in my office who is getting very upset that I'm not going to give them a specific substance because, in my opinion, medically, it is not safe, or it is not going to be the healthiest way to deal with their situation. And, then, their coping mechanism in that moment is to attack my character or my core beliefs. And for example, saying things like, you're not a good doctor, you don't want to take care of me. This happens all the time. Every person I know that's a doctor has had this experience, at least once, if not many, many times with patients. So what I learned kind of through, I guess probably through the hard way, was that, first of all, like, I'm not going to take any of that personal. If I can go home at the end of the day, my boundary is I'm going to provide you with the best medical advice I know I can give you for your situation. And if you have a poor reaction to that, that's something you need to work on. Mm-hmm. And that's something that I will be happy to help you work on. But I am not going to put that burden on myself or take that burden on myself to then affect my emotional state. Because I fully believe I'm giving you the best advice and the best medicine I can.
That's good.
So I think that was a realization, and that took a long time, and it wasn't overnight. It wasn't easy, but it took me a long time to kind of not distancing myself from the patient, but distancing myself from the poor reaction the patient has.
Yeah, that's good.
And then the other thing, and I won't go into the specifics of the situation, but it was a traumatic experience that had nothing to do with the patient treating me bad or anything like that. It's just a bad experience. Like, patients die, stuff happens, right? I think that, and I don't know what the best answer is, and I don't think there is one best answer. I think everybody obviously has their own ways of coping through that, but I would try to remind people to have a strategy, have a thought process or strategy in place maybe before that happens. That's a product of training, right? So learning, what are the skills, what are the things I can do to cope through this and get through this situation? Because unfortunately, we are in a industry where bad stuff does happen, and just stuff out of our control, and just, life is life. If there's any guarantees, right, it's death and taxes. So, mm-hmm. And a lot of people end up dying in front of a healthcare provider. So first of all, please recognize within yourself if you start to feel callous to those situations, or there's no emotional response at all, there's just completely neutral, that may be a sign that it's worth, going to talk to either friends and colleagues or even a therapist about what that means. Because that's a symptom,
definitely,
right?
A therapist.
Yeah, depersonalization, that's a thing, and that's not necessarily the healthiest way to handle that situation. On the flip side, completely involving yourself emotionally in those situations will also kind of wear you out and tax you. That's kind of the beginning. That's the beginnings of the downside. So again, have some, get some training or learn some things. Have a strategy in place going into a shift, going into a situation. If you're about to go into a family room that you have to tell them their loved one passed away or they're about to pass away, and you can just anticipate what the reaction might be and how you're going to handle that, and then what you're going to do afterwards. I will say one thing we did in the military, which I really enjoyed, was after tough situations, we would debrief with the whole team. Mm-hmm. Literally right after it happened, we would get all together and just the different perspectives. And this was the whole team. This was the doctors, the nurses, all the technicians, the support staff. If security somehow was involved, or the other people like other officers of the day or whatever. Anybody involved with the situation gets together, and we just kind of debrief through it. What happened? What did we do? And I will tell you, a lot of positives come out of that. You realize how much you work together as a team. You realize you weren't the only one that experienced what just happened. You realize that other people may have some advice on how they're going to cope with it, or get through it. And so I think that's another strategy that can work really well. It's like a debrief type. And I think a lot of hospitals do that, but that would be another recommendation.
That's awesome, man. You're the man, dude. I missed you. It's good having this conversation.
I missed you, dude.
Yeah, we're gonna have to get together. I know we're going to the beach the same time this year again, so it's gonna be fun to see you, and hopefully get together and have some fun and try to keep the 7 pillars going. You have a 7th one now. You have to keep it.
Who knows? Maybe it'll be 8 next time.
Yeah, exactly. Oh, trust me, I can give. We can ramble and give all kinds of pillars. All right, dude. Any closing thoughts or comments?
I would just, I guess, lastly, I would say to healthcare providers, try to learn about lifestyle medicine, no matter what discipline you're in or what specialty you're in. I think that's something we can all kind of reinforce and talk about with patients, no matter if you're a mental health provider, if you're a chiropractor, if you're a physical therapist, if you're a pharmacist, learn about the pillars of lifestyle medicine, learn how to talk about them with the patients. Because if they're hearing it from multiple people in the medical community, it may start, kind of sinking in a little bit. And then to the patients who may be listening, if you identified with anything I talked about on the show, please go talk with your doctors about it. Look up information on the American College of Lifestyle Medicine. That's a great resource to learn more about it. And again, these are things, they're not necessarily easy, and they don't happen overnight, but they are very positive changes that are sustainable. So, and again, you may be able to come off of some of those medicines you don't want to take anymore, so that's another thing that I remind patients of. They go, they say like, oh, my priorities, I don't want to take all these medicines. I'm like, okay, well, this is what we can do to get you off the medicines.
Yeah.
So let's meet in the middle on that, So anyway, those are probably my parting comments on that.
Okay, good. Yeah, I'd say mine are, if you're listening and you're a professional and you don't understand what Steven's talking about, or you find that difficult, like, call somebody like me in your area, call me, I'll come to your state. I don't care, but get training on being trauma informed, understanding, how to talk to someone, how to have the motivational interviews, learn about, we didn't touch on this, but just human trafficking and abuse and things that people are going through that you might not be aware of in your office because you don't have a understanding of trauma and what people go through in the general population of America or the world at this point. And then if you're a person, you're listening and you're like, man, I keep trying to do these things and these pillars sound great, but I just can't get them done. A lot of that's going to have to do with your mental health and your ability to have someone to walk weekly along with you to see what's going on in your life, to rule out things, to help you, have hope when you don't have hope. And when you're struggling and you don't feel like you can do it, that they can, push you along and help you kind of rule those things out. So, all right, man, that was fun. Love you, buddy.
That was fun.
I'll talk to you.
Awesome.
You did a great job. I mean, that was great information. I think super helpful to professionals, to the average person. Tell your wife hey, and I'll see you soon.
Yeah, same to you.
All right, brother.
Family high.
Thanks for doing it.
Buddy.
Bye.
Yeah, talk to you later, man. Bye.